الكونكشن بليز. دكتور عبد الله احنا شايفينك، سامعنا ولا لا؟
انا سامعكم كمان.
اهلا بيك، كان نفسنا تكون معانا.
السلام عليكم.
وعليكم السلام ورحمه الله وبركاته. كان نفسنا نكون معانا يعني فيزيكالي، بس معلش شويه بقى، وبعد كده ان شاء الله نشوفك اكيد باذن الله فيزيكالي باذن الله.
ان شاء الله ان شاء الله.
نورتنا يا فندم.
الله يخليك. Am I ready to start؟
اوكي كويس.
بتشوفوا المحاضره طالعه عندكم في السكرين؟
تمام ظاهره.
اوكي
احنا كده تمام
ممتاز. السلام عليكم ورحمه الله وبركاته. طبعا نبدا بالحمد لله والصلاه والسلام على رسول الله. انا كان بودي زي ما قلت دكتور يوسف ان اكون معاكم للبلد والناس المحببين الى قلبي، ولكن اجازه المدارس حتبدا بكره، يعني اضطرينا نقعد مع الاولاد شويه. I will talk about Saudi PH registry, some key findings, and I'll try to wrap it up in 15 minutes. As you all know, this is where King Faisal Center is, and when we say Saudi PH registry, it's actually a local for King Faisal institution pulmonary hypertension program, and this is of course Riyadh and King Faisal and Riyadh. So the Saudi PH registry is actually an acronym for a prospective registry. Has been going on for many years now at King Faisal, and the name of the registry or the prospective study is called Systematic Prospective Follow-up for Better Understanding of Clinical Characteristics of Patients with Pulmonary Hypertension Disease. And it's mostly focused on Group 1 pulmonary hypertension and Group 4. We have selected patients of Group 2 and 3 only because they needed some extra care, but the main program, the main registry, two big entities are actually Group 1 and Group 4. So these are key findings, data from these four publications from the Saudi PH registries. And the data analysis was actually covered 3 or 4 years ago. But the program now has about 394 patients, 390 patients are confirmed. And I'll talk about the key findings in PAH group, CTIF group, and some genetic findings are also in our cohort, and a prospective study that has been recently published in the program, in the center. So this is the key findings of the PAH group in the Saudi pulmonary hypertension registry. So at that time, when we did the analysis of the cohort, we had about 242 patients. Some of them were excluded for many reasons, but at the end, the analysis was done for 128 patients with PAH entity and about 68 patients with CTIF group. As you could see clearly that the majority of these patients were actually incident patients. About 80% of these were incident patients, 57% were Group 1 and 30% Group 4. These are the key findings of the registry of the patients with pulmonary arterial hypertension. Strikingly, the mean age is quite young, and compared to the Western registry, it's actually 32 for the whole group, and for Group 4 is 38, nearly 40 years of age. At the presentation, of course, a majority of these patients were actually in Group 3 and 4, and obviously, like what Dr. Arim has mentioned, the majority of patients were actually females, and this is the case in patients with pulmonary arterial hypertension. Mean mean 6-minute walk distance was quite compromised, about 360, but significantly compromised in patients with Group 4, only 214. And of course, the ProBNP was high in both groups. Presence of heart failure was also associated mostly with patients with PAH disease. And this is the components of the PAH patients. Majority of them, again, idiopathic, like what Reem has in her registry as well, followed by congenital heart disease, then connective tissue disease, and then other components of pulmonary arterial hypertension. Now, if you compare this to the Western registry, this is Saudi PH registry, Reveal, Compare, and the French registry. The main difference is, in fact, in the second largest group. So we all have idiopathic pulmonary arterial hypertension, the largest, but the second largest in our cohort is actually called congenital heart disease, followed by connective tissue disease. While in the all Western registry, the second largest is actually connective tissue disease and followed by congenital heart disease. And if you compare this also, I mean, the mean age of the Saudi PH registry to the Western registry, you could see clearly that our patients are much younger, only 32, and the rest of patients, the rest of research, publications in the West were actually much higher, 50 and above. In fact, more recent studies, publication from comparator registry, the age is nearly 70 years of age. But if you look at also at the details of their cohort, there are many patients who have a group 2 and group 3, what they call it also now PAH with comorbidities, group cardiac comorbidities or pulmonary comorbidities. Presentation as well is quite different. In our cohort, 40 to 60% of patients in early functional class versus late functional class, while in the rest of registries like America, French registry, Khmer registry, majority of patients are actually significantly much higher when it comes to comparing to our cohort are actually in functional class 3 and 4. So significantly. And I think this is probably related to two facts. One, much younger age in our group. So younger age normally have better exercise capacity. And that's why a good number of them are actually in group 1 and 2. And the other one is, the other fact is probably because the second largest group in our cohort is congenital heart disease associated. And as you all know, they also do better when it comes to exercise capacity compared to idiopathic or scleroderma related or other things. The etiology, when you do the subgroup analysis of PAH patients, taking away the CTIF group, it actually comes to 45 to 54, the division between the initial functional class capacity versus the late functional class capacity. But this is probably where the change came from. It's 50-50 here. Much more patients with congenital heart disease associated pulmonary hypertension, they do better when it comes to exercise capacity. There is no huge difference between the other parameters. And the mean pulmonary artery pressure at presentation for the whole cohort was 55 millimeter mercury, indicating that quite severe, in fact, at the presentation. And yet, good number of them are actually in early functional class, indicating that the age is actually playing a role in their exercise capacity. Now, baseline clinical and demographic characteristics by etiology, the only difference here is the cardiac index was actually much more in the congenital heart disease compared to the idiopathic pulmonary hypertension. And again, this is quite severe compromised cardiac index. And then again, congenital heart disease, which is also physiologically can be explained, they have a better cardiac output. O2 sat is probably not important, but when it comes to the mean pulmonary artery, they're not hugely different. Now, at the time of analysis, most of our patients, 84% of our patients were actually on a specific therapy. 75% of these patients were actually on combination therapy, which we think was actually good. And I think we benefited a lot from the publication at the time of the early 2000. 11, 12, 13, or 14, when the combination strategy was evident that it's much better than sequential or goal-directed alone. It has to be probably affecting our strategy at that time. So majority of our patients are actually in combination therapy. 63% of them on double combination therapy, and 17% of them were actually on triple combination therapy. That include either prostacyclin analog or prostacyclin receptor agonist. And if you compare that to the Western registry, I think we are also doing better. And I don't know the reason behind this. Looking at all Western registries, if you look at this is a monotherapy, the light blue, the dark blue, double combination, and the green is triple combination. In the Saudi PH registry, if you see, we have majority of our patients, 75%, actually almost 80% of patients are actually in combination therapy. Only 26% of patients are on monotherapy. And part of these patients are actually also calcium channel blocker responders. While if you look at the French registry, Sweden registry, Compara, and other registries, there is a good number of these patients, in fact, are actually on monotherapy, which is quite surprising to us. And but most of these data are actually before 2019. At the end of the analysis, 30% of our patients were actually have improved from functional class 3 and 4 to early functional class. You could see clearly there was actually more now light blue columns compared to the first. And there was significant improvement also in NT-proBNP. About 29% of these patients had a significant reduction of proBNP at the time of the analysis. The survival of the PAH patients, 5-year survival was 74%, and the worst group among those was actually the idiopathic pulmonary arterial hypertension. Understandably, congenital heart disease, they had a good survival. Connective tissue disease, although we know that their survival is not the best when they have pulmonary hypertension, but this is only a small group. It's only 14 patients, so I don't think this analysis should be taken seriously. But the overall survival for 5 years for the whole group is actually significantly better than the Western registers. But if you look at for example, a study of the QK registry, which been published several years ago, they divided their patient to age more than 50 and age less than 50. And if you compare their survival for those patients who have a younger age, it's almost identical to our survival at the Saudi PH registry. So I think, again, age here is playing a major role. While the Saudi PH registry has probably better survival, 5-year survival, than the treated REVEAL patients, but the difference is now is not big. It's 68 and 64. So I think also age is very important. Now, 2 main factors have been associated with poor prognosis, and this has been also mentioned in many other studies: presence of heart failure and right atrial pulmonary artery pressure. Right atrial pressure. Now, this is for the PAH patients. For chronic thromboembolic pulmonary hypertension patient, we have a relatively active program for now 4 or 5 years. These samples of some patients we did. The analysis of this paper was actually when we had 68 patients then at that time, but I brought you a more recent analysis, probably a couple of months ago, this data was analyzed. We have done so far about 97 cases. One was done yesterday and one is today, so we are 99 cases now. And these are the thrombophilia risk factors for this group. And I brought this slide for you just to let you know that the presence of a significant thrombophilia disease, and in this situation, about 49% of our patients are actually related to antiphospholipid syndrome, either primary or associated with SLE. And the reason I brought this one up here, because these patients, they are normally sick, and they also behave differently when they after the surgery. A good number of these patients will, with time, will have recurrent of their pulmonary hypertension. Not necessarily having recurrent PE, but because they have small vessel disease, it normally progresses with time. We have 4% related to cancer. We have 2% had JAK2 mutation, factor V Leiden, dialysis line, and VA shunts. And then this is also very important in clinical practice. 27% of these patients has no history. 1/3 of these patients had no history of pulmonary embolism in the past. So we did so far, I mean, this is 85, but by now we have about 99 cases done. If you look at the operability versus non-operability percentage, it's about 25% inoperable in our cohort. And I think if you look at the international data, they have between 30 to 50% in many studies are considered to be inoperable. In ours, is only 25%. And I think we might be more aggressive and taking risk of high-risk patients as well. This is the outcome when it comes to functional class after surgery. The green ones are actually post-surgery, and the red ones are pre-surgery. And you could see clearly that the red ones, the functional class 2, 3, and 4, they are significantly high before surgery, actually moved to the earlier clinical functional capacity. Now we have 42% of patients has actually functional class 1, and 39% of patients has functional class 2. So the vast majority of patients who actually had the surgery done, they had significant improvement with their functional capacity. And I can tell you, in certain patients, they almost like a newly born patient, because they completely normalize, even if they have some residual pulmonary hypertension related, but because you unload, the right ventricle, from significant PVR in the pulmonary circulation, they really do better functional capacity. Now, when it comes to functional 6-minute walk test, they also do very well. There's significant increase in their functional and then 6-minute walk test post-surgery. The same thing for hemodynamics, significant reduction in mean pulmonary artery, significant reduction in PVR, and of course, improvement in cardiac output, cardiac index. I am emphasizing in this that PAA or PTE, like what the Americans are saying, is actually the gold standard treatment for patients with CTEP, unless patients are inoperable. And you can, in fact, normalize pulmonary artery pressure for this patient. This is a patient of ours. If you look at it, the pulmonary artery after surgery is only 17, the mean pulmonary artery pressure. So I'm emphasizing in this because really diagnosing this patient and treating them surgically, if they are surgically operable, is in fact a major change in their life. Now, the one before last, the genetic study, we analyzed our cohort. Again, this is done also a few years ago. When it comes to the genetic study, we think that because there is, family marriage is more common here in our country, and I'm sure in Egypt as well. We think that the incidence of familial pulmonary hypertension is probably more than outside the Western society. So we analyzed 48 patients with idiopathic pulmonary hypertension and PVOD. We did the whole genome sequencing for them. This is the clinical data of the patients. Majority are female, 89% of them female. All of them, or near all of them, having idiopathic. 2 had a clinical diagnosis, PVOD. And then, as you could see, these patients are actually majority having more than 60% of these patients were actually advanced disease, having late functional class. 6-minute walk test is quite compromised, and their mean pulmonary artery pressure is also as very severe. And this is what we found. We actually found 16 patients of the 48 patients having positive genes, different genes. 4 of these genes were actually the non-PMPR2. 3 patients had the PVOD gene, the EIF2AK4. And a small point here that, remember, we had 2 clinical diagnoses for PVOD, but then there was one patient who was initially diagnosed as idiopathic, actually turned out to be PVOD. And this also has been shown in different other publications that you might actually diagnose patients with idiopathic pulmonary arterial hypertension, maybe even with no family history, but for some reason these patients, when you do the genetic study, they turn out to be positive. So, and the incidence here is more about nearly 30% of patients of our cohort at the time of the analysis having a positive gene. And now we are doing actually the analysis for the rest of the group because we have a much bigger number now. We will see the incidence if it's actually continue to be high and compared to the Western society. Now, the last study I'm going to talk about it is a prospective study called POTENT, a prospective clinical assessment of patients with pulmonary arterial hypertension who were switched from bosentan to macitentan. And we just wanted to see if these patients actually have different outcome. And then just summarize the finding just to let you know that these patients have 1 or 2 parameters that have not been met, or 3 parameters that have not been met. Some of them declining the prostacyclin infusion, and some of them relatively stable, missing 1 maybe or 2 low risk parameters, and we decided just to shift them to bosentan, from bosentan to macitentan, and see if that actually have an effect. In fact, there is actually a significant improvement in their 6-minute walk test at the end of the analysis. I did not put a lot of details here because there is no time, but this study was done prospectively. It is a single-arm observational study. It's not double-blind, and it's for 1 year. At the end of the year, we did the analysis, but these patients had 4 times analysis, each one of them at actually 3 months. So at the end of the analysis, after 3 months, after 12 months, there was significant improvement in their 6-minute walk test for those who have been transitioned to macitentan, 40 meters, and there was also significant reduction of pro-BNP, although the p-value was not different from the other group, at the end, but there was significant reduction. And there was also improvement in functional capacity in this patient. This is visit 0, and to visit 4, see, majority of patients now are actually light blue. Majority of them, 78% of patients, are actually in functional class 1 and 2. And you know, at the end of the visits, at the end of the study now, there are more patients having low risk, at least 3 low risk criteria, and of course those who have higher risk of 40%, they came down to 30%, the 26% improved, and the high risk criteria group actually improved only 14% of these patients at the end of the study. Now, it's also important to let you know that there was 17% of these patients actually deteriorated and required addition of prostacyclin infusion at the end of the observation. So, in summary, the Saudi PH registry, I think the main component that should be delivered to you at the end of this talk is that the age is much younger, is about 32 mean age for PAH and 48 mean age for CTEP patients. They were all actually having disease severity at the end, at the beginning of enrollment, although their clinical functional capacity was actually slightly better than those in the Western societies. And I guess it's because of the younger age and having congenital heart group as second largest group. Right atrial pressure and presence of patients, presence of right heart failure are actually signs of bad prognosis. When it comes to the CTEP analysis, patients who have operable, who are considered to be operable for CTEP should be having, surgery done, because clearly these patients, they do much better after the surgery. And obviously those who are not operable, there are many other things to do for them. This is my talk, and thank you so much for your attention.
Thank you very much, Dr. Abdallah, for this elegant talk and very strong insights of the Saudi PH registry. We are a little bit short on time. If any question from the floor for this fundamental session. احنا session ديت كانت بس بنسخن فيها، بنقول بس البيزكس بتاعت البلمونري هايبرتنشن، انما بعد كده المحاضرات الجايه المفروض ان هي we will unwind the complexity في بقيه المحاضرات، فتتوقعوا ان هيبقى في محاضرات قويه جدا في السيشنز اللي جايه ان شاء الله. If any question please. Yes.
فيما يخص الجزء الاول، انا جيت متاخر شويه لسه واصل، يعني ليا سؤال لحضراتكم اتناقش مع حضراتكم فيه بالنسبه للكلاسيفيكيشن، وهم بداوا يغيروا الترم، بدل ما نقول جروب 2 او جروب 3 ديو 2 حطوا كلمه اسوشيتد. كلمه اسوشيتد يعني برضو حابب اقول لحضراتكم، هل هي المقصود بيها ان هم بينفوا ان هو يبقى الكوز ده ديفينيتيف للبلمونري هايبرتنشن؟ لان حضراتكم لو خدتوا بالكم هم شالوا ديو 2 وحطوا اسوشيتد. تاني نقطه، السؤال شالوا في جروب 3 سليب ديس اوردر ديبريسنج وحطوا هايبو فنتيليشن سندروم. الصراحه البيشنت لما بيجي لنا سليب ابنيا دلوقتي، وزي ما انتم حضراتكم عارفين ان في نايت هايبوكسيميا وفي اكشوال سيكوالي داي افتر داي مانث افتر مانث يير افتر يير بيحصل نايت هايبوكسيميا، وديفينيتيف بيحصل ريموديلنج للبلمونري ارتري، فشيلهم للسليب ديس اوردر ديبريسنج وحطهم للهايبو فنتيليشن. معنى كده ان عيان اوبستراكتيف سليب ابنيا انا دلوقتي اكوردنج للجايد لاين الجديده ان انا مش هحطه كجروب 3 اسوشيتد بالمونري هايبرتنشن. عاوز اعرف راي حضراتكم، اتصرف ازاي مع العيان اوبستراكتيف سليب ابنيا اللي هو اكشوال لسه ستيل نوت هايبو فنتيليتد ات داي تايم، اكشوال ستيل نوت ستيل هو هايبو فنتيليتد، وهو السكور بتاعه مثلا اكتر من 40 وفي ديفينيتيف هايبوكسيميا، ولو نيمته 100 يوم هيطلع برده في ديفينيتيف هايبوكسيميا. النقطه دي شغلانه شويه لان ما بقيناش عارفين نكاتيجورايز البيشنت ده. تاني نقطه حابب برضه اسال الدكتور احمد عبد العزيز، احنا بيقابلنا جزء في التريتمنت مشكله كبيره، الهايبوتنشن ان بيشنت وذ بالمونري هايبرتنشن. صراحه في اي بريسكريبشن لاي دراجز سواء في الفازو دايليتر او السبيسيفيك ثيرابي، العيانين دول معظمهم بيبقوا هايبوتنسيف سايت. البرفيوجن بارامترز بتاعتنا في الاوت بيشنت ما نقدرش نحكم عليها. هل ان انا يعني، والعيانين بيبقى فيه لو كاردياك اوتبوت، في واحد ماشي ب 90 60 واحد ماشي ب 80 50، لما اجي اوصف له التريتمنت اعمل ايه في فكره الهايبوتنشن؟ وهل ان انا مسموح لي ان انا احط فلودروكورتيزون، احط حاجه زي فاسكون، حاجه زي الميدودرين، عشان اقدر احط دايوريتكس وسبيسيفيك ثيرابي ولا لا؟ يعني هما سؤالين شغليننا شويه، واتمنى من حضراتكم الرد، واسف على الازعاج.
طبعا بنشكر دكتور محمد الجمل على الاسئله المحرجه الحقيقه. اسئله قويه قوي. هو بالنسبه للجزء الاولاني obstructive sleep apnea versus hypoventilation، هو الحته دي فعلا كانت فيها بعض الاوبسكيورتي وبعض التساؤلات. obstructive sleep apnea المفروض انها it doesn't culminate to pulmonary arterial hypertension او pulmonary hypertension. what causes pulmonary hypertension هيبقى الهايبوفنتيليشن syndromes، وممكن كمان يبقى ليها امباكت كهايبوفنتيليشن سندروم من ضمن الميتابوليك سندرومز، يبقى ليها امباكت على الليفت سايد اوف ذا هارت اكشولي، وتبقى انت بتتكلم هنا على جروب 2 كمان. لو حصل ان انت عندك ايفيدنت هايبوكسيا والبيشنت على طول هايبوكسيك، يبقى دخل في جروب 3 هو لقيت عنده بالمونري هايبرتنشن. انما هو الاوبستراكتيف سليب ابنيا المفروض ان الهايبوكسيا بتاعتها انترميتنت وفتره النهار ما فيش هايبوكسيا. ف this is a different يعني entity يعني. الحقيقه ان لو لقيت عندك عيان اوبستراكتيف سليب ابنيا واللي في الايكو طالع ان هو عنده بالمونري هايبرتنشن وانت عندك ايفيدنت هايبوكسيا، ما انت عندك كوز فور ذس بالمونري هايبرتنشن، خلاص ده ظاهر قدامك، لان واحد من اسباب البالمونري هايبرتنشن الكرونيك هايبوكسيا، فانت ده خلاص انت كاتيجورايزد على انه جروب 3. اما لو انك لقيت ان العيان ده والله لا ده ميتابوليك سندروم وعنده دايابيتس وهايبرتنشن واوبيزيتي اند سو اون، وفي عنده شويه ليفت اتريال دايلاتيشن، على شاكك ان عنده هارت فيلر بتزيد ايجكشن فراكشن، ده جروب 2. فهي هتبقى هتترك لحكمك انت ككلينيشن على البيشنت. اما الشق الثاني بتاع السؤال كان افتكر ان ده موجه للدكتور احمد عبد العزيز.
طيب الهايبوتنشن، هو بس تعريف الهايبوتنشن مختلف شويه في عيانين الهارت فيلير وعيانين البلمونري هايبرتنشن. يمكن اعتمادنا الاساسي على الكاردياك اوتبوت مش على البلاد بريشر، لان العيانين دول بيتوليريت اللو بلاد بريشر فيري فيري ويل. بس اكتر حاجه تعمل لهم سيمتوماتيك هايبوتنشن هي دايريتكس. يعني لو هنلاقي في العيانين دول significant hypotension عامل لهم symptoms، we strongly recommend ان احنا نريديوس دوز بتاعت الدايوريتكس ون upgrade very very slowly ال specific treatment. اما ان احنا ندي العيانين دول ادويه ترفع الضغط زي الكوراسور والحاجات دي ادويه ما انزل الله بها من سلطان، دي مش موجوده غير في بعض الدول. الحاجات دي completely contraindicated، arrhythmogenic جدا، والعيانين اوريدي دول اصلا عندهم tendency للاريثميا، فايتس completely contraindicated and not recommended in these patients. احنا لما هنحسن الهيموداينامكس as regard the pulmonary artery pressure، الكاردياك اوتبوت هيتحسن، وبعد كده في الاخر البلاد بريشر هيتحسن. بس اتس نوت اور تارجت، احنا جاست الميديكال تريتمنت ويل ستارت سبيسيفيك تريتمنت فيري لو اند جو فيري سلو لحد ما نوصل للتارجت ثيرابي. اتفضل.
قيس الفيتي يعني اكشوال، يعني الشغل البراكتيكال، انا عندي بيشنت هايبوتنسيف، يعني ايه حضرتك البراكتس اعمل ايه؟
حضرتك هتتفاجئ جدا 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 ان العيانين دول ممكن يبقوا ماشيين على بريشر 70 systolic pressure without any symptoms without any low cardiac output symptoms.
انا بشوفهم فعلا كده، بس فكره البريسكريبشن ان هو يكون بعيد عنك وهو ضغطه 80 50 ويكون البلس بريشر بتاعه يعني حضرتك في وايت بريشر، فده بيقلق شويه ان انت حضرتك بتديله دايوريتكس بتديله.
زي ما بقول لحضرتك دي ما تخافش منها خالص. give them the specific treatment. Just monitor the low cardiac output symptoms, not the hypotension. The low cardiac output symptoms, syncope, the low urine output, انما cold extremities, signs of cardiac output بس، انما مش البلاد بريشر. يعني غمي عينك عنه ما كانه مش موجود.
شكرا.
دكتور عبد الله، انا بس ليا فاينل كويستشن. هل السويتش ترايل اللي حضراتكم عملتوها دي غيرت من البراكتس الاون جوينج في السعوديه ولا لا؟
شكرا دكتور احمد. Just remember that this actually was done from 2013 to 2018 when macitentan first came. And once it was available in our center, we actually switched patients for two main reasons. One, at that time, remember, this patient with bosentan, they require a lot of liver enzyme measurements, and this had been cumbersome for patients. And the other one, it's more convenient for patients. They just take it once a day and that's it. There is no head-to-head comparison, as you all know, between bosentan and macitentan. And then when we did that, just because we wanted to do that, and then we said, let's just do it as prospective, fashion. So we see if that actually has a different outcome. And I just want to make it also clear for people that if patients in functional class, high intermediate risk or high risk, they should be treated with triple combination therapy that include prostacyclin infusion. But these patients, all our patients are actually group 3, 2 to 3, and most of them clinically stable, of course. And those days, we look at the targets. The patient is missing 1 or 2 or 3 targets. We add medication for these patients. Now, all of them are actually in combination therapy. There was only one patient who was congenital heart disease, or 2 patients, and stable on monotherapy at that time, bosentan, so we shipped them to macitentan. And all of them on combination therapy. So there is no patient who has been on only one drug that we only shifted him from bosentan or her from bosentan to macitentan. That should not be the practice. But since they are already on dual combination, we actually switched the bosentan to macitentan, and we saw that. In our practice at King Faisal, yes, actually, even before the study, we changed our practice. All patients are actually started on macitentan. We left a small amount of bosentan in the pharmacy just to see, there are some patients who have significant fluid retention sometimes from macitentan, and we put them on bosentan. Or those who have been very stable on bosentan, we did not change them. And then in the most recent guidelines, as it has been mentioned in the previous lecture, a combination of sildenafil and bosentan is not recommended anymore, as you know now. This is also a point that I want to clarify. Remember, bosentan and sildenafil, there was no combination study for that particular combination to check out the primary endpoint for which should be composite morbidity or mortality or clinical time to clinical worsening, except the composite trial. And when they did the composite trial, the outcome was actually not impressive. It was actually negative study. And based on this, and based on the fact that there is no evidence of a good outcome comparing this combination to, for example, tadalafil and ambrisentan in a patient trial, and that's why now in the newest guidelines, it's not recommended to have this combination. But I would not use the term contraindicated. I would just use, it's better not to use it. It's better to use the one we have evidence in it. Either, ambrisentan plus tadalafil or macitentan plus tadalafil or racegot, of course. Thank you.
Thank you very much. We have to conclude our session, and we will ask the next speakers and next chairpersons to come on board. Thank you very much.